Think about the last time you walked into a room and completely forgot why you went in there, or reached for a name, someone you have known for years and found nothing. A blank where a word should be. You probably smiled it off. Maybe said something like, I am getting older, I guess. And everyone around you nodded because that explanation is easy and it fits and nobody questions it. But here's the thing that keeps coming up in medical research and that almost never makes it into a conversation between a patient and their doctor. For a significant number of people experiencing this kind of mental fog, the cause is not age at all. It is something they are taking every day, something they were prescribed, or something they picked up off a shelf without a second thought. And because nobody connects the fog to the bottle, it keeps getting worse, month after month, year after year. While the real cause sits quietly on the bathroom counter being refilled on schedule. That is what this video is about. Not to alarm you, not to tell you to stop taking your medications, but to give you the kind of clear, specific information that allows you to have a smarter, more informed conversation with your doctor than you might have had before. There are certain medications that have been consistently linked in medical research to cognitive decline, memory problems, and in some cases a significantly higher risk of developing dementia. Some of them are prescription drugs taken for serious conditions. Some of them are sold without a prescription, and most people consider them completely harmless. And some of them are doing their damage not alone but in combination, in a way that nobody ever calculated or warned about. We are going to go through each category, explain exactly what is happening inside the brain, and tell you what questions to ask and what alternatives exist. Let us start with something sitting in almost every home right now, often right next to the bed. The sleep aid, the allergy pill, the cold and flu tablet with the word nighttime on the label. These products share a common active ingredient in most cases, an antihistamine called diphenhydramine, and it belongs to a broader chemical family called anticholinergics. That word is going to come up several times today, so it is worth understanding what it means. Anticholinergic drugs block a brain chemical called acetylcholine. Acetylcholine is the messenger your brain uses to form new memories, to maintain attention, and to keep thinking fast and clear. And here's the part that changes everything about how you look at these products. As the brain ages, it naturally produces less acetylcholine and becomes increasingly dependent on every bit it can generate. A drug that blocks acetylcholine lands completely differently in a 70-year-old brain than it does in a 30-year-old one. The younger brain has reserves. The older brain is already running lean. The hippocampus, the region of the brain responsible for converting short-term experiences into lasting memories, is particularly sensitive to this disruption. Research consistently shows that regular use of these anticholinergic products in older adults is associated with meaningful increases in dementia risk over time. And the effect is not limited to high doses or long periods. Even modest regular use can accumulate into a significant burden. The most important thing to understand here is what the labels on these products often do not say clearly. Anything marketed as a sleep aid, a PM formula, a nighttime cold relief, or an allergy tablet for sleep very often contains diphenhydramine as its active ingredient. The branding changes, the drug does not. If you use one of these regularly, that is a conversation worth having. Newer generation antihistamines that do not cross into the brain in the same way are available and are generally considered far safer for long-term use in older adults. But as with everything in this video, the path forward is through your doctor, not through stopping something suddenly on your own. Now let us move to something that affects millions of people who have never thought of it as a brain medication at all. The acid reflux pill. Proton pump inhibitors, which include some of the most commonly purchased medications in pharmacies across the country, work by reducing the amount of acid your stomach produces. They provide real relief for a real problem. Heartburn, reflux, that burning sensation after eating that can be genuinely miserable. And because the symptoms return quickly when the medication stops, many people take these drugs for years without reevaluating whether they still need the same dose or any dose at all. Here is what the research has been pointing to. The stomach needs acid to extract certain critical nutrients from food, and the most important of these for brain health is vitamin B12. B12 is essential for maintaining the protective sheath around nerve fibers and for supporting normal cognitive function. When stomach acid is suppressed significantly over a long period of time, B12 absorption can fall substantially. So does magnesium, another mineral that neurons depend on for clean, reliable electrical signaling. When the brain is quietly starved of these nutrients over months and years, the symptoms that emerge, confusion, forgetfulness, slowed thinking, look almost identical to early dementia. The cause is nutritional depletion from a medication, not neurological disease. And in many cases, when the nutritional gap is identified and addressed and the medication is reviewed, meaningful cognitive improvement follows. Multiple large studies have found an association between long-term proton pump inhibitor use and elevated dementia risk. Some research has also found that these medications may influence levels of amyloid protein in the brain, which is a protein implicated in Alzheimer's disease. None of this means that everyone on these medications will develop dementia or that the medication is always wrong. It means that indefinite, unreviewed use deserves a conversation. The guiding principle for these drugs is the lowest effective dose for the shortest necessary time. If you have been taking one daily for more than a few months without a recent review, that review is overdue. Let us talk now about a medication category that sits in an uncomfortable space between genuine relief and real cognitive risk. Drugs prescribed for bladder urgency and overactive bladder. The most widely known of these works by relaxing the bladder muscle to reduce the sudden, intense urge to find a bathroom immediately. That relief is not trivial. The condition it treats reshapes daily life for many older adults, limiting travel, social activity, and sleep. The medication matters to the people who take it. But here's the problem. The mechanism this drug uses, blocking a specific nerve signal to calm the bladder, uses the same anticholinergic pathway we discussed with the sleep aids. And unlike many drugs, this one crosses the blood-brain barrier with particular ease, meaning it reaches the brain readily and blocks acetylcholine there, just as it blocks it in the bladder. Long-term use in older adults has been associated in multiple studies with significantly elevated risk of cognitive decline and dementia, particularly when taken for a year or more. The fog that gradually sets in is almost never attributed to a bladder medication, which makes this one of the more insidious situations on this list. What makes this more frustrating than it needs to be is that newer alternatives exist that treat the same condition through a completely different mechanism, one that does not involve the cholinergic system at all, and that carries far less cognitive risk. These alternatives are not always offered first, sometimes because the older medication is more familiar, sometimes because cost is a factor. But the option exists and is worth asking about explicitly if you or someone you know has been on a bladder medication for any extended period and has noticed any change in thinking or memory. Now, something that will surprise many people because the medication that comes next is one of the most prescribed and most researched drugs in modern medicine. It protects the heart, it saves lives, and it is also worth understanding more carefully in terms of what it may be doing to the brain in certain individuals. Cholesterol-lowering medications in the statin class represent one of the great success stories of cardiovascular medicine. The research supporting their ability to reduce heart attack and stroke risk is extensive and serious. This is not an argument against statins. It is a closer look at something that gets less attention. The brain is made up of a remarkable amount of fat, and it uses cholesterol as a building block for the insulating material that wraps around nerve fibers and allows signals to travel quickly and efficiently. When cholesterol is reduced aggressively throughout the body, the brain's supply of this raw material can fall below what it needs for optimal function. Not in everyone, not at every dose, but in a subset of older adults, particularly those on higher doses for extended periods. Cognitive symptoms have been reported, including memory blanks, difficulty finding words, and a fuzzy, slowed quality to thinking that was not present before. Some of the medications in this class cross into brain tissue more readily than others. Research suggests that statins with lower brain penetration may carry less cognitive risk for sensitive individuals. If you have been on a statin for several years and have noticed gradual changes in your thinking, it is worth raising with your doctor, not to abandon heart protection, but to explore whether a different statin at a different dose might provide the same cardiovascular benefit with less impact on the brain. The next category is one where the dependency aspect makes everything more complicated. Anti-anxiety medications and sleep medications in the benzodiazepine family are among the most prescribed drugs in the world for adults dealing with anxiety, panic, and insomnia. They work by amplifying the brain's natural calming signal, producing sedation, reduced anxiety, and sleep that feels like relief, especially in the early weeks of use. The longer-term picture is more complicated. These medications are among the most physically habit-forming substances in clinical use, and not because of any personal weakness in the people who take them. The brain physically adapts to their presence and begins to produce less of its own calming chemistry in response. This means that when the medication is reduced or stopped, the symptoms it was treating return, often more intensely than they did originally. That rebound effect keeps many people trapped on these medications far longer than was ever intended at the time of prescription. From a cognitive standpoint, long-term benzodiazepine use creates a kind of broad, chemical sedation across the brain. Learning slows. Mental flexibility decreases. Many people describe feeling emotionally muted, or like they are watching their own life from behind glass. Research involving large populations of older adults has consistently found significantly elevated dementia risk associated with long-term use of these medications, particularly the longer-acting versions that accumulate in fatty tissues, including brain tissue. The path off these medications must be gradual and carefully supervised. Stopping suddenly is not only ineffective, it can be medically dangerous. But tapering under close medical guidance, sometimes supplemented with gentler alternatives or therapeutic support, can free people from a cycle that was quietly extracting a cognitive cost they were never warned about. Let us turn now to an older antidepressant that is still widely prescribed today, and not always for depression. It gets used for nerve pain, for sleep, for headache prevention, for a range of conditions that have nothing to do with mood, which is exactly why so many people taking it do not think of it as an antidepressant and may not fully appreciate what category of drug they are actually on. This medication is one of the most potent anticholinergic drugs still in common use, and its effect on the same memory chemical we have been discussing throughout this video is significant. It blocks acetylcholine strongly and persistently, and when taken at even low doses over months or years, the cumulative effect on cognitive function can be substantial. Studies examining long-term exposure to this class of drug have found meaningfully elevated dementia risk. Physicians who specialize in geriatric care generally consider it one of the medications older adults should avoid when alternatives are available. For nerve pain, other options with different mechanisms exist. For sleep, gentler approaches are available. For depression, if that is the underlying need, newer generation antidepressants carry far less anticholinergic burden. None of these substitutions should be made without medical guidance, but the substitution conversation is absolutely worth initiating. Speaking of antidepressants, there is an important distinction within the most commonly prescribed class of modern antidepressants that very few people are ever made aware of. Most of these medications, the ones you likely know by name, do not have significant anticholinergic effects and are generally considered much safer from a cognitive standpoint for older adults. But there is one member of this family that is a meaningful exception. Unlike its relatives, it carries significant anticholinergic activity, which places it in a different risk category entirely when it comes to memory and cognitive function. It appears on formal lists maintained by geriatric medicine organizations of medications considered potentially inappropriate for older adults, specifically because of this profile. If an antidepressant is needed, other medications within the same general family provide similar therapeutic benefit without the same cognitive risk. This is a specific, actionable point to raise with a prescribing physician, especially if there has been any noticeable change in memory or mental sharpness since starting or continuing this particular medication. Now let us address something that is happening in many care settings and many homes right now, and that very few families fully understand. Medications originally developed for serious psychiatric conditions are being prescribed to older adults for sleep disturbances, restlessness, agitation, and behavioral difficulties, often without the individual or their family realizing that a drug in this category has been added. These are powerful medications that affect dopamine, a brain chemical involved in mood, focus, planning, and memory. When dopamine is suppressed significantly, the brain does not simply become calmer. It becomes slower, less responsive, less engaged. The person may appear more manageable, but they are also cognitively less present. Research involving large numbers of older adults has found that these medications are associated with significant acceleration of cognitive decline when used for behavioral symptoms, as well as increased risk of stroke, dangerous falls, and other serious outcomes. When families observe a loved one who seems to have receded from themselves, who seems emotionally flattened or mentally absent, and attribute it to advancing age or disease, the medication's contribution is rarely examined. The right question to ask any prescribing physician is a simple one. Is this medication truly necessary, and what specifically would be attempted to manage these symptoms before reaching for it? And now we arrive at the point that ties everything together, and that represents the single most important concept in this entire conversation. Individual medications can cause harm, but the most dangerous situation of all does not necessarily involve one powerful drug. It involves several ordinary ones, each with a modest effect on its own, whose combined effect on the brain nobody ever calculated. Think of it this way. A single anticholinergic medication blocks a small amount of the brain's acetylcholine. A second one, taken for a completely different condition, blocks a little more. A third one, perhaps something bought without a prescription and never mentioned to a doctor, adds another layer. None of these medications was prescribed with the others in mind. No one sat down and added up the total chemical burden landing on that one brain every single day, and yet the combined effect can be enormous. Research examining the cumulative anticholinergic burden in older adults has found that those with the highest total burden face dramatically elevated risk of cognitive decline and dementia compared to those with low or no anticholinergic exposure. And the most striking finding is that the majority of people in the high burden group had no idea they were taking anticholinergic drugs at all. The concept had never been explained to them. The hopeful counterpart to all of this is something that is genuinely important to hold on to. Cognitive decline driven by medication is not the same as cognitive decline driven by irreversible disease. When the source of the burden is identified and systematically reduced under medical supervision, many people experience meaningful recovery of clarity, memory, and mental energy. The brain is far more capable of recovery than most people are led to believe, but only when the chemical interference is removed. The single most practical step you can take after watching this video is to request a comprehensive medication review. This means sitting down with your doctor or a clinical pharmacist and going through every prescription medication, every over-the-counter product including sleep aids and allergy tablets, and every supplement you take regularly. Specialized tools exist to score the total anticholinergic burden of a medication list. When that score is too high, unnecessary medications can be safely reduced or discontinued, and safer alternatives can be put in place for the ones that are genuinely needed. This is not about fear. It is about information you deserve to have. Your memory is not simply a casualty of getting older. In many cases, it is responding to the signals your medications are sending your brain every single day. Understanding those signals is the first step toward protecting what matters most. Share this with someone in your life who takes multiple medications regularly, because this kind of awareness, when it reaches the right person at the right time, can genuinely change the direction of someone's cognitive health.